The Columbus Metropolitan Club was founded in 1976 by 13 women leaders who wanted to be included in the community conversation. I am Sally Bloomfield, and I was one of those 13 women. Having been left out of men's clubs that focused on community issues, it was a priority for us to make the club 100% inclusive.
Today, CMC presents public policy forums every Wednesday at lunch with average attendance of more than 200 people. I'm Tony Bell, and I frequently attend forums, which are open to everyone and present relevant, current, and newsworthy topics. I'm grateful that CMC is nonpartisan and presents many perspectives on every topic.
I'm Jane Scott, President and CEO of the Columbus Metropolitan Club. CMC is open to everyone. We invite you to explore the personal and professional benefits awaiting you at the Metropolitan Club. Welcome to CMC.
Welcome to CMC.
Welcome to CMC.
Welcome to CMC.
Good afternoon. Good afternoon, everybody, and welcome to the Columbus Metropolitan Club. Founded in 1976 by 13 visionary women leaders, CMC's mission is to connect people and ideas through community conversation. From its beginning, CMC has welcomed everyone. I'm Deb Hackathorn, the Senior Vice President at Civic Point and a member of the CMC Board of Trustees. So thank you for being here. I'd like to begin by welcoming new CMC members. Please wave if you're here with us today. Judith Cockrell with Elevate Northland, Simon Curran with Knox Gear, Bo Uten with First Harvest Consulting, Michael Farrell with Red Story, Jeremy Gutierrez with Fifth Third Bank, Keith Moody and Sam Cozen with Rev Quest, Eric Lloyd with Denison University, Jennifer Nelson Carney with Epstein, Becker and Green, Jeff Klingler with the Central Ohio Hospital Council, and Brian Fuller and Dawn Hammer Tabata. And our newest lifetime members, thank you to board member Tony Bell with Phoenix Consulting, Brian Kinzelman with MKSK, and Herb Asher. Welcome to CMC. If you're not already a CMC member, we certainly encourage you to join. It's easy to do through our website. Please also take a look at the back of your form flyer today. You'll see all of our sponsors who provide support for our not-for-profit Columbus Metropolitan Club. Half of its annual revenue comes from those sponsors. To join this list of generous sponsors, please see either Jane Scott or Lainey Cuthbert with CMC. CMC's Optimal Health Series is presented by the Ohio State University Wexner Medical Center and Nationwide Children's Hospital. Today's forum is sponsored by Keeler and Nadler, the Ohio Hospital Association, Mount Carmel Health System, Hospice of Central Ohio, OhioHealth, Phoenix Consulting, and the Robert Weiler Company. Today's live stream is presented by the Emergency Response Fund of the Columbus Foundation in partnership with the Columbus Dispatch. Let's thank all of our sponsors. Well, the COVID-19 pandemic has and is prompting hospitals to cooperate in new ways. What did Central Ohio's hospitals learn from the global pandemic? How are hospitals preparing to meet the healthcare needs for the future? Today, we welcome an extraordinary panel, as evidenced by all of you here, featuring the CEOs of all 4 Central Ohio hospital systems. Please welcome Tim Robinson, CEO of Nationwide Children's Hospital. Dr. Andrew Thomas, Interim Co-Leader and Chief Clinical Officer at the Ohio State University Wexner Medical Center. Dr. Stephen Markovich, President and CEO of OhioHealth. And Lorraine Lutton, President and CEO of Mount Carmel Health System. Our host today is Greg Moody, Director of Professional Development in the State of Ohio Leadership Institute at The Ohio State University John Glenn College of Public Affairs. You can learn more about today's speakers in your forum flyer. Greg, take it away.
Welcome. It's really good to see everyone. We are fortunate in Central Ohio to have multiple strong hospital systems. Many communities do not have a choice where to receive care, but we do. Our hospitals compete on access, services, and quality. And when necessary, they collaborate. For example, in response to COVID and other threats to public health. The leaders of these hospitals are here today, and I'm excited for you to meet them. To get started, please reintroduce yourself, and you are all fairly new in your current role, but most of you have a long history with your hospital. How well do you know each other? And in this highly competitive market, how do you balance collaboration with competition?
I'm Steve Markovich, President and CEO of OhioHealth. I've been with OhioHealth for 30 years. To your point, I've been with the system for a long time. I've been in this role going on 3 years. The idea of, we call it sometimes co-opetition. You know, sometimes we collaborate, sometimes we compete, sometimes we cooperate. We've gotten to know each other, I think, fairly well. A couple of us have known each other for years and years, back from previous roles, previous relationships. Lorraine, I think, is relatively new to the team. But we've gotten to know each other very well through what we call the Central Ohio Hospital Association. That's how we brand ourselves when we come together for policy and conversation. It's a great team to work with.
Andy Thomas, as was announced, I'm Chief Clinical Officer at Ohio State is my day job, and I'm filling in for about a 9-month period of time as our co-CEO or co-leader for the medical center. I've been at Ohio State this summer will be 31 years. Came as a med student and pretty much been there ever since. So I think the comments about long history in the place, that's certainly helpful in whatever role I've had, is having relationships and actually seeing a lot of people from even the other health systems here today that I haven't seen personally in 2 years in face-to-face, but we've been on phone nonstop. But it was those relationships, frankly, in the community that helped us respond to COVID the way we did. Rustin is relatively new to town, but you filled great shoes at Children's. Nick is here somewhere. Nick Kritzoulis at Mount Carmel similarly, and Terry's not here today, but just it's been a great partnership. And I think going back, I know some OHA colleagues are here today. When Dave Engler used to pull all the quality leadership together for well over a decade for meetings, sharing data, because I always said, you know, to be honest, the closest hospital to my house is Riverside. So I want it to be good quality because I might show up there someday, right? So, you know, we can compete on a lot of things, to your point, Greg, but I would never want to have there be low quality at another hospital. So that's an easy thing for us to partner on. And I think the COVID relationships really grew out of that as a community need. So.
Tim Robinson, Nationwide Children's, have been at the hospital for 27 years and 3 years in the CEO role. And I think have the most tenure on the panel now. Steve and I really just came in at about the same moment, and it's been great to welcome Lorraine to the community. And she's just really been great partner as she's stepped up in that role. You know, we're in a unique role as Nationwide Children's. We partner with all 3 of the adult systems. We have our neonatal intensive care units in all their hospitals. We partner in so many different ways. And maybe as almost a independent observer, as I look around the country and talk to my peers, we just have such an incredibly rational healthcare delivery system here in Central Ohio, and high quality care. Really found that, you know, the right size, the whole commitment is remarkable to see. No community hospital, no indigent hospital. Literally all 4 hospitals take their fair share in making sure all the folks in the community are served. So it's a really great environment and a great honor to be partnering with all of them. Lorraine?
Thanks, Tim. Lorraine Lutton, and I'm the newcomer of the group. I joined the Mount Carmel Health System in April of 2000, so right in the middle of the pandemic, which was a blessing and a curse, right? The curse is I couldn't get out and see Columbus and meet people face to face and build relationships. However, the blessing was aligning with these 3 people next to me. Every week we were having conversation about what's going on, what do we need to look at, where's our PPE, what kind of visitation policies, who can we borrow things from? I mean, very much together. And I credit the Central Ohio Hospital Council and Jeff Klinger and the Ohio Hospital Association for really helping foster that collaboration. I think throughout the organizations at every level, our lab directors were talking, our supply chain people were talking, our HR people were talking, everyone was connected. And I think that fabric really got woven pretty tightly during the trials, the greatest parts of the pandemic and the greatest challenges. So I'm grateful to be here and thank you for your hospitality.
Thank you. Well, let's continue on that theme just for a second. COVID was hard. We want to get past it, but risks persist. What did you learn? What did your systems learn from the pandemic, and how will that improve care going forward?
I'll start. I learned we have wonderful people in healthcare in Columbus. You are blessed, and this community is blessed to have very, very committed people. And the second thing I would learn is we can take nothing for granted. We didn't think we'd run out of gloves or gowns or masks or supplies. Who would have thought that we would be facing some of the challenges we face? So great people, take nothing for granted. And I think to the extent that we align on a lot of other community health initiatives, the work through the pandemic has helped that. And will continue to help that. If we're looking at, the next thing might be monkeypox, or who knows what it will be. But we are going to continue to use the structures and the relationships that we built in response to COVID.
If that wasn't the topic for my 6:30 call this morning, I would laugh that it's going to be monkeypox. But no, I think, I don't know if Mashika Roberts or Joe Mazzola are here. I saw, there's Mashika waving. I don't know if Joe's here or not. But, there, good. Hey, Joe. They are the Franklin County, the leaders of Franklin County Public Health and Columbus Public Health. And I have to say, part of what we all relied on was them as a convening entity, bringing us together as a safe space to talk. And I think that's another just level of partnership with the public-private space, whether it was MORPC or other groups that Joe put me in front of to talk about COVID with other local leaders, or the mayor's office wanting feedback from all of us. The public-private partnership is, I think, something we probably take for granted more here than we should. Amy Andres is there. Amy was moving the National Guard around the state with the governor's office, and as she works at Ohio Hospital Association. Even at the state level, that public-private partnership is something we can't take for granted here. We need to keep foster and nurture.
It was the level of coordination. You can't wait till the crisis to build the relationships. And the beauty was we had relationships to start with, and it really trumped the economics. Clearly, when we got into COVID, there were things happening where one system could take advantage of it over another. There were points in time when beds were so full, let's say at Riverside, that they had to curtail elective surgeries. And that would have been a great opportunity for another system to call all of our physicians and say, hey, we're open, bring your cases to ours. And what we agreed to was that we would behave as one. If we were going to have a visitation policy, which I know frustrated a lot of folks, we can only have one visitor or no visitors, we were all going to have the same policy. If we were going to curtail elective surgeries, we would do that together, so that there was no opportunity to take advantage or a perception that we were not talking. And it really worked out very, very well.
This is a little dangerous to do, to call out one individual working with a great team, but Andy really did lead our region for the statewide initiative and spent a lot of time, making sure that not only the hospitals of Central Ohio, but of the whole region were taken care of, and really coordinating their efforts, and spent a lot of Sundays and Saturdays on the call for all of us. So really want to acknowledge his important role there. A couple of observations, at least from the view of children. One is the incredible impact it's had on different populations, the disparities that we saw, whether it's underserved populations or minority populations, and why our work in population health and addressing social determinants is so important. The work that the partnership is doing around prosperity is I think been amplified even more. And then the other area that we've really seen as a major issue is obviously behavioral health. It's an issue for the adults. It's been a huge issue for children as we work our way out. We had a crisis going into the pandemic where 1 in 5 children needed behavioral health services, and only about half of them were being seen around the country. And then the pandemic hit, and we're seeing that impact and really trying to lean into it as a community with the schools and do everything we can to get our kids back in good form. So those are some of the observations.
Thank you. So as someone who watches a lot of national hospital markets, what you're seeing is pretty unique, and I think also really sincere. There is something about the connection here in this community that we benefit from greatly. Leaning into that a little bit, we talked a little bit about the competition, how it's friendly competition. I want to specifically commend you on one type of collaboration. I want you all to know that Central Ohio stands out nationally for its cooperation among hospital systems and public health departments, which was just mentioned, but specifically in identifying specific threats to public health and setting priorities for a community-wide response. There is a brochure at your table about these priorities: increasing access to mental health and addiction services, reducing overdoses and overdose deaths, reducing infant mortality, and prioritizing health equity while serving increasingly diverse populations. Now, it used to be hospitals did their own community health impact study, and we had 7 or 8 of them in Central Ohio because each public health department did that too. Our community, earlier than most, got pretty well organized on that, to the extent there is now one plan identifying those priorities. A huge accomplishment. So maybe if each of you could say a little bit about what those specific priorities are and how together you're working on behavioral health and opioids and infant mortality and health equity.
I can start with behavioral health. You may not be aware of this. We mentioned this right up front that we compete in many, many ways. We compete for access, we compete for talent, we compete for quality. But when it comes to the things that are really, really important to the foundational elements of a community, that's where we get together, and many of the issues that you mentioned. Behavioral health is a challenge across the country. It's a challenge here in Central Ohio, and we try to come together where we can to try to address those needs. And it's through relationships beyond us. I mean, the Ohio Department of Mental Health and Addiction Services, the Adam Board, the not-for-profits, there are freestanding mental health facilities in the Columbus metro area, Franklin County. We work together to try to manage that population, both the inpatient population and the outpatient population, in a very appropriate legal way, not from any antitrust perspective. We have an electronic bed board that was created that we look at all the capacity in this across Franklin County every morning to try to make sure patients don't have to languish in an ER who need our services. It's really, really important to get those folks the care they need. Behavioral health, I'll speak for my colleagues. Behavioral health is not a big money maker for hospitals. It is something that truly comes from our mission, and we need to make sure that those patients are cared for, and we try to do it in as efficient and cost-effective a way as possible, but you've got to get them plugged into the system. Not just on the inpatient side, but the outpatient side. When patients are in crisis, sometimes they need mental health services that may not warrant an admission to a psychiatric unit for acute services. So Franklin County and the Adam Board right now is in the process of developing a new and very much enhanced crisis center that the 3 adult systems came together to provide the seed money, about $8 million to get that going. And we're really proud of the work that the Adam Board has done in making that happen. You're going to see a theme today is probably the best thing that comes out of this is that we talk. We talk about the community's needs. We talk about best treatment protocols. We talk about how to manage patients, how to make sure that patients don't get stuck in the system. And then even on the outpatient side, when they need follow-up care, we collaborate. Children's has really stepped up with the investments they've made in pediatric behavioral health, and adolescent health is still a challenge for the community because we have a really smart community, and that in many cases, children will migrate. They'll find their way to children's because the rest of us really don't do peds, true peds. Adolescence is something we all need to think about, and because as you can see, we look at the data, and we do share a lot of data on depression, suicide, addiction services. Those are things that we need to be talking about, especially in that adolescent population. There's a tremendous unmet need.
And I'll comment on opioid addiction and death. We've had a number of years in partnership again with Columbus and Franklin County, the goal to reduce addiction death, specifically narcotic death. And we've had, in 2019, we had 547 residents of Franklin County die of opioid addiction and overdose. And then in 2020, as a result of the pandemic and isolation and everything else, it went up to 804, almost a 50% increase in opioid deaths. Now, last year, it went down 5%. Woohoo, down to 765 deaths. That is too many. An average 2 a day is just too many deaths of our Franklin County residents. And the health systems have come together over the years, really starting, I think, probably back in 2016, 2017, to do a number of things. First, reduce the number of narcotic prescriptions we're writing. So we look at GI procedures like gallbladder surgeries and hernia repairs, et cetera, and we gather data and report it quarterly to each other and through the Central Ohio Hospital Council. And we've had more than 50% reduction of the number of pills we're prescribing, but also the rate, what percentage of patients who are having those surgeries get opioid prescriptions at all. And we're moving that to C-sections and total joints, and we're really trying to focus on let's not initiate narcotic prescriptions when we can avoid it. The second thing, so if we can't avoid it, we already have a prevalence of folks who are addicted. How do we better manage it when they come to us? So between 2020 and 2021, about 5,700 patients a year come to our emergency departments collectively. And we've done a number of things in partnership with the public health departments. One is have a REACT team, which is a rapid response team to come and respond to patients who are in our emergency departments, with mental health nurses and peer counselors and outreach coordinators trying to, for those patients who are willing to seek treatment at that time, immediately get them into a treatment, transport them, get them to a facility that can help them address this issue. If they're not ready for treatment at that time, give them Narcan, give them a kit, such that they can, if they're going to use, they can be prepared for the overdose and reverse that as quickly as possible. I can go on. There are a number of other things. Our street medicine team, I'm glad Dr. Kanzler is here, our medical director of our outreach street medicine team. They do amazing work with people who are homeless and have combinations of both mental health and addiction challenges. And so just a lot of great work for all of us. And again, commend the coordination and collaboration.
Maybe I'll lean in now on infant mortality. As having the largest neonatal network in the country, we see the implications of this. And about 10 years ago, the hospital systems came together and formed OBO, the Ohio Better Birth Outcomes Initiative, which is a lead partner for Celebrate One. Dr. Roberts and Karen Morrison over there, who chairs the Celebrate One committee, have been working on this for a long, long time. And back in 2014, 8.8 babies died for every 1,000 births. By 2020, we've actually improved that to 6.7 deaths per 1,000. And that's about 150 babies' lives that we saved during that time. Unfortunately, the health disparities are still there. So Black babies are 3 times more likely to have infant mortality than white babies. And so the new strategic plan for Celebrate One and translating down to OBO is that we need to really attack those disparities. And I think you'll see that us leaning in really hard through all of those initiatives. For Ohio Better Birth Outcomes, we're focusing on access to prenatal care, making sure that we have capacity for home visitation for mom and for the baby, to even before birth and after birth, to really make sure that they're successful. Providing perinatal support like legal aid and smoking cessation, and then really working with our women's health professionals and attacking unconscious bias and making sure we understand how systemic racism affects prematurity. So a lot of good work, a long way to go.
Highlight, in addition to what Tim shared, outside of infant mortality, we think there are still far too many differences in both access to care as well as health outcomes related to either someone's race, someone's socioeconomic status, or someone's gender identity or sexual orientation, not only just in this community, but more broadly in Central Ohio. And as we've talked about Appalachia, you have facilities up and down in rural parts of the state as well. And you have your whole network in the southeast part of the state. So I think we as a set of organizations we're going to have to find new ways to partner around studying health equity. In fact, later today, you're going to see an announcement. We've hired at Ohio State a new Chief Health Equity Officer. He's joining us from the Mayo Clinic, where he runs their Center for Health Equity Research. And we see as an interdisciplinary study, so it could be the College of Social Work, it could be the College of Nursing. It's not all just the College of Medicine. A new opportunity for studying health equity with the partnerships we have here on the clinical side and the questions we all have about how to do this better, and having a research arm within the university with our land grant mission we all talk a lot about what it might look like in Linden or what it might look like in the metropolitan areas, but I do think we also struggle in our Appalachian areas and rural areas of the state. So we're going to be looking broadly at these issues. With great partners like this, I think there's nothing we can't tackle.
Thank you. So you each talked about kind of general for community-wide, some of the collaborations in those specific areas. And you made the point also that health impacts communities differently. Some of the most challenging health outcomes are in some of the zip codes near your hospitals. How are you opening your doors into those communities? What are some specific connections into the community that are specifically addressing that issue of health equity?
I can start. I wanted to foot stomp something that Tim said. I make sure everybody hears it. In Central Ohio, there is no county hospital. In Central Ohio, there is no healthcare tax. The systems have come together that had to say, whoever walks in the door, we will take care of. Whoever walks in the door. You need open heart surgery tomorrow, you can get open heart surgery tomorrow. You need prenatal care, you'll get prenatal care. And we all have the same charity care policy. So it's not like we've gamed the system where anybody, you're disadvantaged by going to one system for anything that you might be charged or have any out-of-pocket expense. So we've tried to level the playing field just so people are encouraged to use the system. And then what we try to do is we try to invest in those communities. I'll give you an example of OhioHealth. You know, we identified 3 underserved communities that clearly needed primary care offices across Central Ohio and the Columbus metro area. And we put those in. And these are offices that function in a special way. They're designed, I'm a family doctor by training. A normal family doctor might have 2,500 patients in their panel. These doctors have 400 patients. And the expectation is that they manage the health of those people in a different way. The office has pharmacy built in, it has social work built in, it has transportation built in to try to help those people get the access they need to try to, frankly, keep them out of the big hospitals. So that's one of the examples of what we're doing.
So I'll reference back to 1999 when Dr. Sigurnis, who many of you know, had a very visionary approach of actually buying what was then the Park Medical Center on the Near East Side. It was ready to close, had a very low census, but a very busy ER. If you remember, it's hard to remember the times before Medicaid expansion when that was where people were predominantly getting primary care in that community. It's now, you know, it as OSU East Hospital, but we've continued not just to buy that hospital, but to partner and grow the healthcare services in that community and partner outside of the healthcare space. So PACT, or Partners Achieving Community Transformation, is a partnership between Ohio State, the Columbus Metropolitan Housing Authority, and the City of Columbus. And then we all put in dollars to then leverage a large federal grant to really change that neighborhood in a substantive way. And now we're actually had worked out a land swap with the library, where they built a new library location on our property, and we bought the old library location in the old Martin Luther King Library. And we're reimagining that as a community healthcare center. So that's just one neighborhood where we're working, but I think all of us have different location commitments around the city. Wineland Park was another major one right next to the university, where we've committed a lot of time and effort on everything from education to healthcare. So.
Go ahead, Tim.
On the pediatric side, we're blessed. Most kids are healthy, but what we know is what really drives their overall health and wellness are the social determinants of health. You know, high quality, affordable homes, adequate nutrition, schools, the whole 9 yards. And so we started an issue of healthy neighborhoods, healthy families on the south side around our campus about 14 years ago. And since that time, under Patty McClymon's leadership, we've done over 500 affordable homes. We've worked in the schools. We've brought healthcare to it. We've got educators going to people's homes to make sure that kids are kindergarten ready. And now we've expanded that effort to the Linden community. So we're really looking to do what we did in the past 12 years and accelerate that and do more in the next 5 years in both of those communities. So very leaned into to making sure we're addressing those social determinants.
Well, and I would just add, Mount Carmel has a number of significant investments and commitments throughout Columbus to serve those who don't have better access to care. We have retained our commitment into Franklinton. Although we moved Mount Carmel West to Grove City 3 years ago, our Franklinton campus remains our central hub for our community health and well-being outreach activities, from healthy cooking to mental health services to trauma services. It really is a very comprehensive approach to caring for residents in that neighborhood, and that's also our hub for serving the rest of the rest of the community as well.
Thank you. Thank you. And just the tone of this conversation, the focus on those upstream factors that ultimately impact health downstream, that was not a common conversation in health systems 15, 20 years ago. And I think these health systems were leading the way in essentially creating resources and financing to address some of those issues. You mentioned the Medicaid expansion. Everyone here was active in accomplishing that. As I look around the room, I think the majority of folks in this room played a direct role, somehow contributing to the accomplishment of that. So again, another example of the community really, really coming together when it matters. What about the workforce? How's it holding up? So, together you're among the largest job creators in Ohio. As an employer and an economic engine, what are your biggest challenges? But then also specifically, what are you doing to support your workforce?
I'll start on the challenges. All kidding aside, we need, just like every other industry, we need a better workforce, a stronger, a more capable. I mean, we just need more people at all up and down the organization. It's not just nurses, it's not just imaging techs, it's housekeepers, it's respiratory therapists. It is up and down the organization. And inflation in healthcare, one of the things you may not realize, we have such a complicated financing system. But we can't just pass on cost to patients or to payers or to the Medicare and say, hey, the bill got bigger because we had a 19% increase in our labor cost or 18% increase in our supply cost. So can you help us make that up? They have very long budgets, and our managed care plan, our agreements usually last, a couple of years. And so they're not willing for us to say, hey, can you help us out? So we're right now in a challenging position of trying to address to wage inflation, which is significant and real. And we want to fund and compensate our people to, it's a law of supply and demand. I went to business school, rates are going to go up. So how do we make sure that we are taking care of our people and investing in our people well? So beyond money, which I think we could all talk about a little bit, we have done a lot of things on colleague care. From rounding and respite rooms and, pet therapy. And I think all of us have done a lot of things to try to strengthen the resilience of our colleagues. But at the end of the day, it's each other. What nourishes our colleagues and our teams is each other. They are loyal to each other. They sacrifice for each other. They come together. So how do we live our mission and inculcate that feeling of worth and value and teamness in a way that inspires our colleagues to continue to invest and sacrifice to take care of you and your neighbors?
Yeah, I'll dovetail off that. I think from a physician perspective, we're recruiting a group of physicians for the most part that want to have a little bit different path through medicine. They want to be in the academic environment, whether they teach or do research. Outside of a couple specialty areas that frankly have a shortage nationally, we're not having difficulty recruiting physicians. But the licensed providers, the nurses, respiratory therapists, I think what we've all seen is some of the folks who were at the older end of the age spectrum, the COVID pandemic was enough to say, well, maybe I'll call it a day. Some of them also decided maybe I'll go work in an ambulatory setting where there's a little bit more sense of control. And then some of the folks younger in their career journey have decided to travel and make 2.5 times what we are paying them to travel and do these 3-month gigs at hospitals around the country. Now, I think we're all hopeful that some of those folks are going to come back. We've certainly got a number of travelers in at our place. We're trying to keep as many of them as possible now that they've seen our environment. But that's for kind of licensed folks. I think the most complex one is the unlicensed individuals that Lorraine mentioned. In that case, if you're a transporter, you work in food services or environmental services, my competition to hire people is not these 3 people. My competition is like being a cashier at Home Depot. My competition is, working in one of your businesses, making the same amount. Now, luckily, we made a decision the summer before COVID, so I guess that would have been summer of 19, to move to a $15 minimum wage across our system. Had we not done that at that time, I think we would be even further behind on a lot of those jobs. But the key thing is having those folks see a career path forward in our organization. It's easy when you're an entry-level staff nurse and you have a nurse manager and a nursing director, you kind of can see a path forward. But to have people realize that it is a career opportunity to be in healthcare, and it's not like you're going to do this job as a transporter forever, to see it as a career path. So that's one of our goals, to create a career pathway for individuals in unlicensed roles so that they stay in our industry.
We look at it really through four lenses. There's a recruit, retain, redesign, and relationship. Recruit, obviously, talent, it's out there. Some of it's left, but truly, how can we work with our universities? How can we work with our academic other partners to make sure we've got a pipeline that we can recruit into? We've got to retain our associates, and that's what drives that is culture. Clearly, economics are part of it, and we've got to get creative. It's base comp. I can only do so much. What can we do to give, make sure we've got a benefits package that's very, very attractive, help with student loans, help with all sorts of other things. And then this idea of redesign. Nothing is more wasteful than to have people that are especially licensed folks, credentialed folks that are operating below the top of their license. So we have to redesign the work. If you've got a licensed nurse, he or she has a tremendous number of skills they bring. They shouldn't be doing tasks that don't require that licensure. So how do you redesign the work? And lastly, it's things like it's the relationship that you have with your associates. I'll give you an example. So we have a thing we do at OhioHealth. Once you reach 20 years of service, and every 5 years after that, we have an event. And we couldn't do it for the last couple of years because of COVID. So we literally about a month ago, we rented out the zoo for the evening. We had 3,000 associates who had been with the company more than 20 years. We gave them the day off. We gave them an economic package and said, come on out and we're going to celebrate. And we had bands and we had food and an opportunity just to see each other and recognize their contribution to the healthcare community. So taking care of your people, I made that commitment when COVID started. When it first started, OhioHealth has a long history of great stewardship. And we've got decent assets. And I said, we're not going to lay anybody off no matter what happens. And we literally had about over 2,000 people at one point that were getting a paycheck not to come to work. And we just kept them whole. We committed to their economic well-being, their mental well-being, and then their clinical well-being to make sure they had the resources to take care of patients like PPE. So all of us are in the employment business. You've got to do those kind of things to keep the talent that you've got.
Incredibly challenging times for us. It's what's the value proposition? Our staff want balance in their life. They want the growth opportunities, and they want purpose. It's very, with a line of sight to our mission, our strategic plan, I think it's very easy to live on purpose, but really balancing that balance and the development while also taking care of our patients and families and bringing that together. And so, looking creatively at every way possible that we can really enable them to be fulfilled and retain them and be able to attract the new folks. The other big part of this is the pipeline. And on Monday, it was great. Lorraine and I welcomed 70 of our youth employment program. Young people, very diverse, very energetic, very engaged. We put this together quickly last year without a lot of time, and we already had 30% of those folks returning. We hired 9 of them. So just every one of us are focusing on how do we develop that pipeline, how do we exploit things like the Columbus Promise, and really develop the flow of talent into our organizations, but do everything we can to retain them and develop them.
Fantastic, thank you. We'll move to questions from our live stream and in-person audiences in just a few minutes. If you have a question, please make your way to the microphone now. If you're watching online, please type your questions into the chat. But before we take audience questions, I have one final question for the panelists. And you all have a really hard job. And listening to how you're working together to handle it, I think is inspiring. But what is it that inspires you? So if you think about innovation, for example, over the next 10 years, what is it that's coming that is so worth it that you continue to provide leadership in your current role?
But it starts by walking down the halls in our organization and seeing the children and families in need, but the work that we're doing around behavioral health, the work we're doing around population health, and some of the new research that's coming online, whether that's gene therapy or tissue engineering, a whole host of initiatives really gets me inspired. I don't think we've ever been at a point like this in science where we're really seeing it translated into new cures and treatments. So it's an exciting time. This group of people inspire me too, down there in this table.
I agree with that. The thing that keeps me coming to work every day, and I tell this to my people all the time, number one thing is the mission. Number two thing is the people. You can't do the mission without the people. You got to, and it's the most important people are the people on the front line, the people that are delivering trays of food, cleaning the rooms. But when you say long-term, Greg, what's, the idea that personalized medicine, that we're going to be able to look at your DNA and your genome and be able to craft a treatment plan that's tailored to you, I think that's mind-blowing to me.
Yeah, I think, one of the newest innovations we have coming online here in a year is we're jointly collaborated with Children's on proton therapy, things like that are just really unique in the region. But I think looking at some of the things we're doing with gene therapy, we've just started a new gene therapy center at Ohio State. We're actually able to inject genes directly into certain centers of the brain to change someone. So you take these young children with ADCC. It's a very rare disease. It's essentially a juvenile form of Parkinson's. They never walk, they never talk. They oftentimes are deceased by the time they're barely 10. And within 2 to 3 months, those kids are walking, throwing a ball, getting in fights with their siblings. It's the videos we get from the parents, and it's been a great collaboration and partnership with Nationwide Children. Things like that are really incredibly inspiring. I think the other one would be artificial intelligence. We have a huge focus on that from a research perspective in our College of Engineering, around the university, kind of for all industries. But what we see in healthcare, one thing we haven't talked about yet is all 4 of us now are on the same electronic medical record, which is a big step forward. Thank you, Lorraine. But that artificial intelligence piece is really going to, I think, revolutionize how we deliver services, so that people can make sure we're getting the right care at the right time, and using that artificial intelligence will only forward that.
And just quickly, 2 things. I would echo Tim's comments on walking the halls and actually engaging with our colleagues who are delivering great care. Anytime I need to fill my bucket, I just go to one of the sites and do rounding. But secondly, what excites me is the real transformation that's going to occur in the next 10 years around healthcare. Just like every other industry has gone so sort of asset heavy to asset light, bricks and mortar, you go to the bank and you cash your check, and now you just use your phone. Healthcare is doing the same thing. And so how do we use technology and innovation to provide care where you want it in your home, whether it's through your phone or through all these peripheral devices where you can, get an EKG now with your cell phone? How are we going to do that and transform the care and partner with patients and in a different way that allows more empowerment of the patient themselves?
Thank you. I was just reflecting on the health records. The first bill I worked with the congressman I worked for, Dave Hobson, was to standardize health records in 1992. And so there is a lot of perseverance to this, but I
30 years?
But I think you also hear the sense of wonder, right? That we really are on the threshold of some changes that can be profound, and not just on the clinical side, but in how we organize to get upstream and avoid unnecessary poor outcomes. So it's exciting. Thank you for the conversation. It is CMC's longstanding tradition to take audience questions. Jane Scott of CMC is curating questions from today's live stream audience. And for our in-house audience, please join Jane at the microphone. Please keep your questions brief and to the point. Jane, our first question.
Wonderful. Well, thank you. Thank you all for your leadership in this community and for your willingness to share your thoughts with our CMC audience. I think that's just tremendously unique for our community. So thank you very much. There are lots of questions, so I'll go quickly. You talked about competition. We all can see the cranes. There's lots of building going on. How do you control the cost of competition and all of these capital projects? That's a balancing act. How do you do it?
I can start. It's interesting. We have about $3 billion of stuff under construction. If you look at our research facilities, education facilities, our outer belt strategy, you've all seen hopefully our new Albany facility that opened last summer. We have one in Dublin opening this summer. But from the hospital perspective, which is the big project you see going down 315, we're replacing a 1950s hospital, right? So we will add 300 beds to our current facility, but we think that's growth that'll keep us for the next 25 years. With each of our outer belt sites, we bought enough land so we can build hospitals. But think about what Columbus is doing. You've all seen the projections of adding 1 million people over the next 10 to 20 years. I think Intel has even accelerated that change faster. One of the things that we all have as a luxury is we have a growing local market. I think a lot of communities that don't, the competition doesn't look so nice at the head table when you have 4 CEOs, when it's not a growing community. Well, we have that luxury but for us, it's growth, but it's really replacing 1950s facilities that frankly don't meet the community standard any longer.
There is a lot of sometimes construction, sometimes programmatic growth. At OhioHealth, we target for every dollar we make, we want to keep a nickel. And we're a not-for-profit, as we all are here. That 100% of that nickel gets plowed back into the community and into our organization. So sometimes, to Andy's point, you're refurbishing facilities that may be old. Parts of Riverside have been around since the late 50s. So you've got to. It's a very capital-intensive business. So you need to reinvest, refurbish. And then in today's world, things are moving more and more to the digital space, but access is still important to the consumer. The idea that you would drive across town to get to your doctor or to get to the hospital of your choice is really not viable for the long term. So how do we create a reasonable amount of access that is affordable to the consumer, but at the same time represents really what the consumer is demanding?
And I'll just add, we did open Mount Carmel Grove City, and I see Ike Stage here. We 3 years ago, and it's doing really well. It's just a beautiful campus and a beautiful facility. But that was a relocation of an old existing building that was failing, that really needed to have significant investment wherever it was going to be. Aside from that, we're actually moving towards a more asset-light strategy. And so we are looking to put a health campus up on the east side of Dublin, but it'll be mainly ambulatory focused. We really think that we're trying to try to help keep people at home and provide convenient care, but keep them home.
And at Nationwide Children's, we just launched our new strategic plan, and we have about $2 billion of investments. But all of that starts with programming, whether that's clinical care, research, or education. It all starts with what that demand is and what the requirements are, and then we build the buildings in support of that. And I think the other thing you mentioned, this community is growing, but we are now seeing patients from all 88 counties, from all 50 states, and about 50 foreign countries. So in addition to the domestic growth that we have this onslaught, providing the best care anywhere in the world. Well, patients come in, but then also the children in this community get the best care. So that's really what drives that.
Thank you. The next question, and to get as many questions as we can, I'll move us along a little bit. Your next question.
Hi, Jeffrey Feld with Geosci Consulting. This has been wonderful. This is my first hospital panel, so thank you to the organizers and the panelists. So we were talking about innovation, and I wanted to talk a little bit about genetic diagnostics. So there's a company, Ultima Genomics, just came out of Stealth like a week or two ago, $600 million in funding, that says that by next year they'll have a $100 genome, which, something in 2000 we could have never imagined. So I want to know at what point, so this really has the potential to change medicine. So Tim, you had mentioned population health. So for example, we'll see, being able to look at sequences from people other than just European heritage and really understand human health. So I wanted to know, at what point does genomic and other omic technology diagnostics become part of routine healthcare, and what are the hospitals doing to kind of prepare for that moment?
Well, I'll start. I think it actually already is a pretty routine part of some parts of healthcare. It's a futurist that I see at national meetings sometime. He likes to say the future is already here. It's just not evenly distributed yet. So when you think about cancer care, cancer care, and you made this comment earlier, I mean, we can target exact drugs for people's exact genetically on the leukemia lymphoma side, as well as the solid organ cancer side. So I think transplant's another area where, the genetic markers of who can get which organ is really critical. So it's there. I think the tough part, from my perspective, I'm a primary care doc as well. Seeing someone who's 30 and looking at their genome and understanding, are they the one with that genetic pattern who's going to go this way or that way, is difficult. I was just discussing a patient's lipids with them in the office yesterday and trying to figure out what they're going to do over the next 10 years. It's still through a glass darkly a little bit more than people realize, unless you have one of those specific diagnoses that really we have a path forward with it.
On the kid side, most childhood disease has a genomic underpinning, and we set up a center about 5 years ago, the Institute of Genomic Medicine, and they are actively engaged with our clinicians, providing support and diagnostic and helping with treatment. And then the gene therapy that follows on from that is coming out of that as well. So it's a big platform for us and already in action.
Next question.
So this question's online from Grant Hesser. As it relates to Medicaid, specifically in forthcoming state-based redetermination efforts, how do you foresee this potentially impacting uninsured volumes, and how do you plan around that? That's his question. I don't even understand the question.
Yeah. I can maybe give you a little help on it. So during the pandemic, there's been an emergency so that if you were on Medicaid, you stayed on Medicaid and you didn't have to do a redetermination every year. So over the past several years, people have just stayed on the rolls and more people are insured. And we've seen that in our population. We have an accountable care organization that has 475,000 Medicaid kids across the state, and that's grown dramatically. The concern is now they're going to turn that off. They've extended it through the next quarter, but as they do, people are going to fall off the rolls. And for us, that usually translates to kids not getting access to care. And so we're very active in trying to develop strategies to make sure these parents make sure that they get their children re-enrolled, and they can do that in an effective way. And we're working with the Department of Medicaid to do that. And they've tried to automate that to a great deal, but there's still going to be a large concern that people are going to fall off the rolls.
And in Ohio, the administration has advocated doing that at the point the federal government says to turn it off over a period of time. The legislature has interest in doing it a little quicker. So that question around how that rolls out is a policy question that you all should be aware of. Next question.
Hi, I'm Yima John, and I'm a CMC member. Thank you guys for being here today and having this open. Okay, thank you. So we had mentioned the topic, the subject matter of health equity in our health systems, and just really how COVID exposed that gap amongst our own population and everything like that. And one of the programs I think that really helped in this area, I feel like, was school-based care. I was just curious, what does the future of that school-based care look like in terms of closing that gap of health equity, as well as in terms of the employment side of things, having more diversity amongst the physicians and people providing the care for these populations? Thank you.
Yeah, on school-based, it's a great question. We've worked very hard to get primary care access into many of the underserved communities. We have 13 primary care sites in underserved, but even with that, there are children that aren't getting access. And so we've started by developing school-based clinics to really provide access to preventive care and to primary care, as well as programs around asthma and diabetes. We have behavioral health services in the schools. So we agree it's a really important way to expand access yet to that next level.
In terms of diversity on the provider side or on the system side, we have targets within OhioHealth. We have targets for the global organization, for administrative leadership, for physicians, for our residency programs. We have expectations for diversity to help fuel that. because it's hard to drive that in some cases. We have a partnership with OU's College of Medicine down in Athens and in Dublin and across the state. They have a couple other campuses where we have a diversity scholars program where we actually help fund the medical school of diverse students that are going through the process with the hope that when they graduate, they think we're good people and they come work for us.
Yeah, this summer we have, this has probably been almost 20 years now, MD Camp, which is about a cadre of about 25 high school students from Columbus City schools who come through and are shown the vision of what their career can be and how the pathway forward moves through college, et cetera. So I think we all have similar programs.
And I would just add, with our Mount Carmel College of Nursing, we also have scholarship dollars available, and through the Kathy SB Fund and others to support and grow diverse talent pool in the future. But we've got the same targets and are striving to increase our diversity as well.
I don't know how you all feel, but this time goes so fast. We have time for one more question.
Estimates show up to 80% of chronic illness comes from human behavior choices. Where does this fit into your priorities as far as investments in wellness, health and wellness, training, prevention, and all the things we should be doing right?
Well, I can tell you in our space, whether it's coming out of the sports medicine side of things or just the community engagement piece, Healthy New Albany was our first foray into this. We have partnerships with the YMCA around Columbus, getting health coaches out into YMCAs. We have a partnership with the City of Upper Arlington on their new community health center where we're engaging with everything from counselors to physical therapists to other sorts of health and wellness type professionals. We have partnerships with local schools as well. We're not just providing them athletic trainers, but all the way up to psychologists and counselors. So we try to take that preventive focus and working, frankly, with each community on how they need those services and what they need in their communities. We don't want to show up and say we're from Ohio State and we have all the answers. We work with them and what their needs are, whether it's the city of Columbus or whether it's one of our suburban communities.
Really excited about a program we're piloting with our Medicare Advantage plan called MediGold, which is an outstanding Medicare Advantage plan. We are using, we have peripheral devices where patients are home monitoring and reporting. We have a 24-hour call center with nurses tracking results of that peripheral monitoring. So your blood pressure is off, your weight goes up, whatever that is, and trying to intervene and really, again, empower the patient or the member to manage their own care, to really use that as a training tool. One of the things we're doing also within MediGold is an isolation study where we are pairing young people with Medicare Advantage patients to see if isolation can be addressed through sort of a documented process of living their history and their lives and trying to connect people back to the community in ways that that try to address isolation, because it is a very significant impact on overall health.
So happy to admit being wrong. One more question.
I'm happy to be the last question of the day. My name is Ella. I'm here at Columbus State and Phoenix Consulting. I am currently studying to become a reconstructive surgeon, so I'm pre-med. My question is about the long-lasting effects of the pandemic on the healthcare industries. Because I know with the Ebola outbreak, a lot of people were stricken with poverty, and that made it harder for them to seek healthcare, and a lot of hospitals there were not making any money at all. So do you think the COVID pandemic has anything of the sort that you are kind of forecasting, any long-lasting impacts that you'd find hard to overcome in the future?
Well, the long-lasting impacts of COVID are going to be, it's going to be multifaceted for a number of years. I mean, the clinic, we continue to, and I have a lot of favorable thoughts about my research colleagues to my left, people that are studying COVID clinically and the long-term impacts, long COVID, all those things. The economic impacts are going to be devastating for quite a while, not just what happened to the workforce, but I don't think we really know yet how many people that have lost loved ones, lost family members, the economic impact of that and what it's doing to everything from, dollars flowing into a family to childcare to, being able to bring folks up, to be productive adults. So we've never seen anything like this in my career. And I still, what we just went through for the last 2.5 years is really, it's unimaginable. I think it's going to need to be studied for a long time, but to my public health colleagues, I think we can't get caught resting in terms of what we think about the future and how we're going to respond to the next issue.
I would just say after 2008, when we had the Great Recession, there was a dramatic impact on children and their health status because of those social determinants. This is even more profound because you not only have that, but you also have the loss of development that occurred as kids were out of school, and then the behavioral health issues. So this has got a long tail for children, for sure.
Medicaid expansion's already been mentioned a couple of times, but I can't imagine what going through the pandemic would have been without people having expanded coverage through Medicaid. I think it would have been far different even than it was. I think also it's sitting here in a room like this today. It's kind of hard to remember that 5 months ago, we were all in the middle of not doing elective surgeries for 6 weeks. That was just 5 months. That was not, 3 months ago, we still had almost 1,000 people in the hospital just in our zone of the state with COVID. So we'd like to think this is over. We'd like to think we can come to events like this. The next variant comes along, we could be back in square one if it's outside the vaccine. So obviously, knock on wood, prayers, all those things that doesn't happen. But I think what we've learned over this past 2.5 years, we will keep applying and move forward.
And don't forget those people. There were a lot of signs, healthcare heroes and the Blue Angels and the Thunderbirds toured the country to recognize healthcare folks. When you're a nurse on a small unit, you have 6 patients die in one night, and that happened at Riverside. That's a devastating toll on you emotionally as a caregiver. So there's a whole generation of folks that are direct bedside caregivers that I don't know are ever going to be quite the same. And there are a number of people that have just said, I can't take it anymore. I'm going to retire. I don't want to do this again. And so we need to remember those people and really the emotional trauma that's been levied on some of our associates, the ones that are out there really on the front line. Those people are way deep in my heart.
And on that note, we're getting the hook, guys.
Yeah, you are definitely getting the hook. I hope you feel like we're in good hands here and really proud of our Central Ohio system. Please make plans to join us at CMC next week for CMC's annual State of Nonprofits, featuring a panel of nonprofit leaders you will not want to miss. Thank you to the Ohio State University Wexner Medical Center and Nationwide Children's Hospital for presenting CMC's Optimal Health Series. Thank you to today's sponsors, Keeler and Adler, the Ohio Hospital Association, Mount Carmel Health System, Hospice of Central Ohio, Phoenix Consulting, OhioHealth, and the Robert Weiler Company. And special appreciation to today's speakers, Tim Robinson, Dr. Andrew Thomas, Dr. Stephen Markovich, Lorraine Lutton, and our host, Greg Moody. Thank you for being here. Let's give them a round of applause. See you next week.